Welcome and presidential address.
I think we can start off the program, Murli.
Okay.
Nishantine കേറാനായിട്ട് ബുദ്ധിമുട്ടുണ്ടെന്ന് പറഞ്ഞു. ഡോക്ടർ നിശാന്ത് ഉണ്ടോന്ന് നോക്കാമോ?
Dr. Nishant ഉണ്ടോ?
നിശാന്ത് ഉണ്ട്.
Yes.
Okay. So let us start the meeting.
Hello.
Yes, sir.
Hello, let us start the meeting. I am Dr. Murli Krishna, President of IDA Malnad. I am welcoming you all. Chief guest of the day, Dr. Nishant Krishna, CDE Chairman, IDA Kerala State, Honorary Secretary of IDA Malnad, Dr. Pradeep Philip George, CDE Chairman of IDA Malnad, Dr. Ronin Sebastian, Speaker of the day, Dr. Baiju Paul Kurian, veterans of Mar Baselius Dental College, Advocate C.A. Baby, Secretary Mar Baselius Dental College Association, Dr. Varghese Pani sir, Indian Prosthetic Society Office Bearers, President Dr. Rohit Raghavan, Secretary Dr. Rupesh, Moderator of the function Dr. Arun George, Dr. Brijay, Secretary of Academic Forum, Mar Baselius Dental College, and dear members, let me welcome you all to the first CD program of complete denture, post-insertion problems and solutions in association with Indian Prosthodontic Society, Kerala State, and Mar Baselius Dental College, Kodamangalam. This is a very useful topic for clinicians as we encounter this on a daily basis. As we all know, we have just finished our branch installation on 22nd on Saturday, and we are up and running with our first CD program. So I congratulate our CD chairman for arranging a CD program so early. IDA Malnad has been forefront in conducting CD programs, and this is evident from the awards that we have won in the state and national territories. Our CD chairman is hello.
Yes.
Yeah, is very enthusiastic in running all the CD programs. We look forward to conducting more such CD programs, even offline also. Thank you. And with this, let me conclude and welcome you all to the first CD of IDA Malnad. Thank you. Now I welcome our chief guest of the day, Dr. Nishant, CDE Chairman, IDA Kerala State, to inaugurate the program.
Thank you, Doctor. Am I audible? Ellarku kekkamo?
കേൾക്കാം.
President Dr. Murli Krishnan, Secretary Dr. Pradeep Philip George, CDE Convener Dr. Ronin Sebastian, ഇന്നത്തെ സ്പീക്കർ ഡോക്ടർ ബൈജു പാൾ കുര്യൻ സർ, ഇന്ത്യൻ പ്രോസ്റ്റോഡോണ്ടിക് സൊസൈറ്റി സെക്രട്ടറി ഡോക്ടർ രൂപേഷ്, പിന്നെ മറ്റ് സീനിയർ മെമ്പേഴ്സ്, IDA മലനാടിന്റെ മറ്റ് സീനിയർ മെമ്പേഴ്സ് ആയ ഡോക്ടർ എലിയാസ് തോമസ്, ഡോക്ടർ സിജു പൗലോസ്, ഡോക്ടർ ജോസ് പോൾ, ഡോക്ടർ ജിജു ബേബി ജോർജ്, ഏവർക്കും എന്റെ നമസ്കാരം. ഞാൻ അധികം വലിച്ചു നീട്ടുന്നില്ല. IDA മലനാട് ഇങ്ങനെ ഒരു പരിപാടി ഉദ്ഘാടനം ചെയ്യാനായി എന്നെ ക്ഷണിച്ചതിൽ അതിയായ സന്തോഷം. IDA മലനാടിന് കേരള സ്റ്റേറ്റ് ബ്രാഞ്ചിന്റെ എല്ലാ ഭാവുകങ്ങളും ഞാൻ ഈ ഒരു അവസരത്തിൽ നേരുകയാണ്. അത് മാത്രവുമല്ല, ഇനി അധികം നീട്ടാതെ തന്നെ ഞാൻ അതിന്റെ ഔപചാരികതയിലേക്ക് കടക്കട്ടെ. ഔപചാരികമായി ഈ ഒരു വെബിനാർ കംപ്ലീറ്റ് ഡെഞ്ചർ പോസ്റ്റ് ഇൻസർഷൻ പ്രോബ്ലംസ് ആൻഡ് സൊല്യൂഷൻസ് എന്ന ഈ വെബിനാർ ഔപചാരികമായി ഉദ്ഘാടനം ചെയ്യുന്നതായി ഞാൻ ഇതോടുകൂടി അറിയിച്ചു. നന്ദി.
Thank you, Dr. Nishant. Thank you for the inspiring. Now I welcome Indian Prosthodontic Society officer Dr. Rupesh for the felicitation. Dr. Rupesh?
Yes, can you hear me? Yes.
Yes, sir.
Yes. A very warm greetings and good evening to all of you from the Indian Prosthodontic Society, Kerala State Branch, and its President and the Executive Council. Let me at the onset bring you all greetings from the IPS head office, the Kerala State head office also. We had recently celebrated our Prosthodontist Day a couple of days back. So let me also bring greetings to each and every one of you on this occasion of Prosthodontics Day, and the celebrations are also continuing here. And Dr. Baiju has been very magnanimous enough to have come forward and be part of this this particular event in connection with this the Prosthodontics Day event also. The IDA Malanad and the friends from the IDA Malanad branch, a big thank you to each and every one of you. The Mar Basilios Dental College and the Academic Council of Mar Basilios Dental College, I think a big kudos and shout out to you all from the Department of Prosthodontics. And of course, I should also be thanking Dr. Murli Krishnan, the President of IDA Malanad, Dr. Pradeep Philip, Secretary, Dr. Ronin Sebastian, and a big thank you, Dr. Nishant, the State CDE Chair, who's been here as the Chief Guest. A big thank you for your presence here, Dr. Arun and Dr. Brijesh. A big thank you. Finally, let me also offer my compliments to my very good friend, Dr. Baiju Paul Kurian, who is a speaker for today, and he is going to speak on a very pertinent topic, which, like Dr. Murli just said, is probably a topic which will be of paramount interest to practitioners per se, because they will be encountering such an issue, probably on a day-to-day basis. So, like all, I'm sure a lot of students are also joined in, and I'm sure, maybe a recording of this can be done, and probably it can be presented at some, old age homes or public, where people generally the people are all, geriatric patients and things like that. So that also will be of much benefit. So my heart goes out to each and every one of you, and my good wishes to this particular function. Thank you very much. Thank you, Murli.
Thank you, Doctor. Thank you very much. Now, to introduce our speaker, let me call our CDE Chairman, Dr. Ronin Sebastian. Dr. Ronin.
Good afternoon, all. Am I audible?
Ronin, 1 second. I think Dr. Rohit is also here, our president. Yes.
Yeah, please, sir. Dr. Rohit, can you have a few words?
Rohit? Dr. Rohit?
Yeah, am I audible now?
Yes, Rohit.
Yes, sir. Yes, sir. Please. Sir.
Thank you, Dr. Murli Krishna. I won't take much of your time. I'll go directly. On behalf of the Indian Prosthodontic Society, Kerala State Branch, and on my personal behalf, I would like to convey to each and everyone present on this virtual platform a very warm New Year greetings and best wishes. Now, as you know, prosthodontists all over celebrate January 22nd as the Prosthodontist Day. And as part of our celebration, we have planned a series of webinars and continuing dental education programs. The Indian Prosthodontic Society, Kerala State Chapter, is extremely happy to be associated with the Indian Dental Association, Kerala State Branch in general, and the Malanadu branch in particular, in conducting this webinar on post-insertion problems and solutions in complete dentures by Dr. Baiju Paul Kurian, Professor and Head Department of Prosthodontics and Principal of Mar Basilios Dental College, who also happens to be a very good friend of mine and of ours, I could say, and an executive council member. I'm sure that he will enlighten us in this particular topic, and I wish him the very best. So I would like to conclude by thanking the patrons, Advocate Baby and Dr. Verghese Mani, President of IDA Malanadu, Dr. Murli Krishna, Secretary, Dr. Pradeep Philip, CD Chairman of Malanadu branch, Dr. Ron Sebastian, CD Chairman of the Kerala State, Dr. Nishant, for the platform extended. Thank you once again. Jai Hind, Jai IPS.
Thank you, Dr. Rohit. Thank you. Now I call upon our CDE Chairman, Dr. Ronin Sebastian, to introduce our speaker of the day, Dr. Baiju Paul Kurian.
Good afternoon, all. I would like to welcome our speaker of the day, Professor Dr. Baiju Paul Kurian. As his past student, I am honored to introduce him to you. He is an academician and a private practitioner since 22 years. He is a fellow in Noble Biocare and trained in DPS dentures. His practicing interest is on aesthetic dentistry and implantology. He is currently the principal, professor and head Department of Prosthodontic at Mar Basilius Dental College, Kodamangalam, and has various publications in national and international journals to his credit. He is passionate about dental implants, BPS dentures, aesthetic dentistry, and maxillofacial prosthetic rehabilitation. He has conducted numerous continued dental education programs. He is also the director of Dr. Kurian's Specialty Dental Clinic and Implant Center, Moatura, and a proud member of IDA MALANADU. Welcome, sir. Welcome to this platform.
Thank you.
Dr. Baiju.
Good evening.
Good evening. Now the forum is open for you, Dr. Baiju, for your lecture.
Yeah. The screen is, can you share the screen?
It is visible by the
Yeah, it's visible, Doctor. Yeah.
Respected President Dr. Murali Krishna, Secretary Dr. Pradeep Philip, IPS President Kerala State Dr. Rohit Raghavan, IPS Secretary Dr. Rubesh, Kerala State, CDE Chairman Nishant, CDE Chairman Malanadu Branch Ronin Sebastian, my dear fellow colleagues, practitioners of Malanadu, postgraduate students, good evening to one and all. It is really happy to take up a topic for the practitioners as well, as we are going through the 50th year of celebration of Prosthodontic Society. And complete denture problems after the insertion is of key interest of choice by our President, Murali Krishna, saying that it will definitely help the practitioners. I am so happy that my own branch has started up the webinar in connection with the Prosthodontic Day, which we had celebrated on 22nd January. Always complete denture, when we say about the complete denture fabrication, it is really a time-consuming procedure. A lot of patience is required in the fabrication of the denture. And we find that to convince the geriatric patients, always we find difficult, because you get the patients will be coming out with a great expectation when you go in for a complete denture. They always like to get a denture which has got a chewing efficiency as that of a normal dentition. But with our all efforts, taking into account of all the anatomical structures, giving prime importance to the anatomical structures, you fabricate or you make an impression to the insertion. There are a lot of things to be taken into account. And if you take carefully all these things into account, definitely the problems involved can be reduced. And today, my topic, I think that the practitioners and the audience who are attending it will be able to get enlightened to a certain limit or certain parts of the problems and how to handle it in your future practice. There is, when we see the complete denture, there is inevitable potential for the problems to arise subsequent to the fabrication or from the insertion. So it is not that running away from all these problems only increase the delay to find out the solution. So it is always that we have to update the knowledge, or we have to see that the latest trends in the materials, the latest trends in improvising the skills in each step of the complete denture can readily decrease the post-insertion problem. Still, a well-fabricated denture can cause certain sort of post-insertion problem. So you must always be able to predict what next, and then the flexibility to evolve to that. So here, the two different types of the post-insertion problems which we come across is the problems which can be solved by modifying the denture to a certain limit, or the problems which get solved by the ability of the patient to adapt to the treatment. So what does this two things mainly emphasizes is the problems can be by modifying the denture. Modifying the denture in the sense starting from the primary impression and you land up with the actualization of the denture. There are small things which happens with our slight negligence or during the fabrication. So that can be slightly corrected at the time of insertion. You have to verify each step with prime importance. So the problems get solved by the ability of the patient to adapt to the treatment. That is by motivating the patient to making understand. A new denture wearer is always difficult to make him understand. And we need to give him the assurance that this is the only means and method by which he can wear a denture. That is more important. So the patient psychologically, to convince the patient is also very, very important. So what are the common problems, the two types of which we normally find is discomfort, looseness of the denture, adaptation of the problems of the denture, retention and stability problem, and other difficulties. These are the common things which we come across when we go in with a complete denture fabrication. So when we say the discomfort, it is related to the impression surfaces of the denture. When we see the impression surface, the inner surface of the denture, when you do the insertion without careful attention, there will be some problems related to that. Relating to the occlusion and the polished surface of the denture, associated with some possible systemic associations, the problems which the patient can create some sort of discomfort. The factors resulting to the looseness of the denture may be due to the decreased retention forces, maybe increased displacing forces, or sometimes arising to the anatomic and the occlusal factors involved in the occlusion of the teeth which we have placed. So these are some of the denture looseness related to the retention and displacing and the occlusal and the anatomic factors. The third one we come across is the adaptation of the problems of dentures. That is sometimes when the denture adaptation the patient finds difficult while eating or while speaking, with some of the problems which the patient finds. So what will be the reasons related to that? Eating difficulties sometimes the patient finds because the lower dentures sometimes become loose due to the movement of the tongue, or sometimes the overextension of the dentures may lead to the ill-fitting nature of your lower denture. Sometimes the patient complains about the gagging. So when we see about the gagging, the gag reflects maybe some sort of an overextension in your denture. So these kind of things we need to identify. And the problems of the speech, there are certain factors which are involved in the reasons for the speech or the clearness of your pronunciation related to your teeth arrangement, related to your vertical dimension. So these are some of the problems which we come across. And all these problems which we need to address one by one. So here I would like to say that related to the impression surface, when we see related to the impression surface, when we evaluate the impression surface, sometimes you will be able to see discrete painful areas of the onto the tissue surface, pain on insertion and removal of the denture, pressure induced painful areas, overextension of the lingual flange, the painful mylohyoid ridge, or the denture lifts on the tongue protrusion. These are some of the things which we come across when we give a denture to the patient. Lack of relief of the freni or the muscle attachments, which starts pinching off the tissue between the denture base and the mucosa, sore throat, difficulty in swallowing. These are all some of the discomfort or the problems which we come across related to the impression surface. So when we see the discrete painful areas, you can see that there will be some sharp or pearls or the sharpy ridges of the acrylic over the fitting surface arising from maybe due to some laboratory processing error. So how do you tackle that? When we get a denture prior to the insertion, you need to apply apply a paste which is or the pressure indicating paste over the tissue surface and try to keep it in the patient's mouth and locate if there is any nodules in the acrylic. Or you can run the a gauze piece over to the tissue surface, and you can find that sometimes it will get entangled to the nodules. If you find such kind of sharp edges of the acrylic that needs to be removed properly, which is some sort of error which can cause due to or which can happen during your impression step. Sometimes you find that when you make a final impression, if the salivary secretion is more, sometimes that may create some pores in the impression surface. If that is happening, definitely that will come as an elevated surface of the cast, which on acrylization, which becomes like a nodule. So that definitely, if you are going to insert in the patient's mouth, definitely that will lead to some sort of ulcerations in the tissue surface, which we need to taken care before you do the insertion of the denture. Now, the pain on insertion of the removal of the denture, some sort of undercuts, if it is there, you need to locate the undercut, and you need to, with the help of the disclosing material, adjust the area, slightly trim off and polish the surfaces properly, so that you will not create any sort of ulcerations in the patient's mouth. Pressure-induced painful areas. What do you mean by pressure-induced painful areas? Sometimes the relief areas are not being relieved properly. We say that, normally we say that the stress-induced area and relief areas we say in the impression, and we find that if it is not being relieved properly, definitely that may lead to the stress-induced area, which may lead to ulceration of the tissue surface. Sorry, warpage of the denture surface area. So the lack of relief and warpage of the denture surface area will lead to the some sort of ulcerations onto the tissue surface, which we need to be attended before we give the denture to the patient. So if severe, refabrication may be required, or if some patients, if any sort of remnants of any root stems or anything, if it is still there, you have to see that before going into fabrication of the denture, that also has to be removed. Another very much taken care area is the overextension of the lingual flange. Overextension of the lingual flange, or definitely that is commonly creates a painful mylohyoid ridge, the denture lips on the tongue protrusion, and leads to the painful swallowing of the saliva. So the cause that is overextended lower impression, you need to see that always the anatomical limitation has to be taken into account when you do the bottom molding. Determine the position and extent of the overextension and relieve the area completely before you go in for your final impression. Generalized pain on the over the denture supporting area. So that is underextended denture base resulting from over adjustment to the periphery and inadequate freeway space would lead to a generalized pain over the denture supporting area. The extension of the denture to the optimal available denture support area has to be noted. If insufficient freeway space, we have to see that the denture has to go in for remaking. Sixth one, we find that is lack of relief of the frenile. Always we find that when we deliver the denture, we have to look into the point that whether the frenum is being properly relieved or the muscle attachments is it being properly relieved, pinching of the tissue between the denture base and mucosa. So this common reason for this to happen is the peripheral extension or the overextension resulting from overextended impression. So we have to look into the point that this is being properly relieved with the aid of a disclosing material, and care has to be taken care that if there is any overextension into the post-dam area, that has to be taken care. Now I am coming on to the problems associated to the occlusal and the polishing surfaces. So related to the occlusal surfaces, the pain over the lingual to the lower anterior ridge, pain or inflammation on the labial aspect of the lower ridge, pain about the periphery of the dentures, possibly accompanied by the pain in the masseter, the posterior to the temporalis, cheek or the lip biting, tongue biting is another reason which we find with the, or which we come across with the occlusal and the polishing surface. So you have to see that these areas has to be taken care when you go in for a denture insertion. And onto the polished surface, pain at the posterior aspect of the upper denture on opening. So the pain over the lingual anterior ridge, the pain, always we have to see that the lingual to the lower anterior ridge, definitely the cause will be the overextension. That is, you are not supposed to give a denture with overextended borders. Always an overextended borders will affect the retention of the prosthesis. That is the key thumb rule. You have to avoid at any point of time. And overextension, mark the deflecting inclines of the posterior teeth with a thin articulating paper. If slide exceeds half a cusp width, re-register and we have to reset it. That means your arrangement and the positioning of the teeth is very, very crucial. Pain or the inflammation on the labial aspect of lower ridge. If no impression surface defect, maybe the lack of incisal overjet causing the incisal locking. So the treatment is reduce incisal vertical overlap. If the appearance compromised, reset the anteriors may be required. So we have to check into the criteria and the importance, in what way it is required. Pain and or the inflammation on the labial aspect of the lower ridge, that is in the lingual most aspect, and the pain about the periphery of the dentures, possibly accompanied by the pain in the masseter as well as the posterior temporalis muscle. This is again an important factor which we come across, the vertical dimension of occlusion more than the patient can tolerate. So always our jaw relation is very, very important. We have to see that the 2 to 3 mm freeway space is very important. And if some or the other way, if that is being compromised or we have gone wrong, definitely it is less than 1.5 or greater than 1.5. Both will create these kind of problems to the masseter as well as the posterior temporalis muscle. Lip or the cheek biting, that is likely that the functional width of the sulcus, was not restored, and the poor lip support, inadequate anterior horizontal overlap. So that is very critical related to our teeth arrangement, the teeth positioning, as well as the jaw relation. When we are fabricating the denture, the jaw relation, anterior positioning is very important. Your lip fullness and the posteriorly the lips, the buccal support is also very important. So that if we are not being properly recorded, or the teeth arrangement, if it has gone out of the arch, definitely that may lead to the cheek or the lip biting. Now the tongue biting again is another problem which we come across with the complete denture patients. The lack of the lingual overjet is the reason for the cause for the tongue biting. Teeth generally placed lingual to the lower ridge. That is more towards the lingual aspect. Remove, if you find that is your teeth arrangement, when the technician does the teeth arrangement, and if you find that it has gone too much towards the out of arch, you need to see that it is to be corrected, or remove the lower lingual cusp and reset it. You have to recorrect the teeth arrangement. You should not go or proceed with what the technician has sent you back. Now, pain at the posterior aspect of the upper denture on opening. That is normally what we have to be looking to at the time of your impression procedure. That as with the primary impression as well as with your secondary impression, the flange on the buccal aspect of the tuberosity becomes too thick and constraining the coronoid process. That means you have not properly recorded the lateral movement of the mandible when we do the lateral movement of the mandible, the coronoid process will help you to record the posterior extension of the maxillary denture. And if that is not being recorded and that the denture area, it becomes very thick, that means the pain at the posterior aspect of the upper denture on opening, also that will lead to the dislodgement of your denture. So you need to correct the thickness in the posterior limit. Now I am coming to some of the systemic factors, related to some systemic factors that we find, something like the burning sensation of your upper denture, the frictional lesions related to the denture mucosa, tongue thrusting, presence of ulcers in the mouth, painful click related to your TMJ on opening or closing of the mouth, tenderness of the muscles of mastication, and patient complaints of allergy to the denture material. These are some of the related systemic factors which we come across: the burning sensation of your upper denture, as well as the frictional lesions of the dentures mucosa to adhere to the probing fingers, tongue thrusting, or the presence of these ulcers. What we will see that one by one, how or what are the causes for it. That means the burning sensation of your upper denture supporting tissues must involve either the intraoral tissues, that is the middle-aged or the elderly females mainly affected, the denture faults and the psychogenic factors. So we need to give them some sort of multivitamin therapy or sometimes an antidepressant therapy. Same way, if you find that some patients will be having allergic to the monomer. The monomer which is not, when we are processing a denture and before the delivering the denture, it is mandatory that from 24 to 48 hours, this denture has to be immersed in plain water for 24 to 48 hours. That will help us, the unreacted monomer, to leach into the water. So any sort of the monomer, unreacted monomer, if it is leaching into the oral cavity, that also can create some sort of burning sensation. So immediately after alkalizing the denture, you are not supposed to give or deliver the denture immediately. Now the frictional lesions related to the dentures, the dentures mucosa may adhere to the probing finger and complaints of the dry mouth, something like xerostomia, that is the dryness of the mouth, and commonly the side effects of the prescribed drugs. And these kind of patients where dryness of the mouth is there, some salivary substitutes can be given, or you can advise the patients to use some sort of citrus juices to stimulate the saliva for the patient's mouth. As you all know, that is salivary secretion and saliva plays a pivotal role in retention of the denture. So that we need to take into account, and dryness of the mouth will also affect the retention of the denture. Now tongue thrusting and empty mouth chewing, that is a neurological or psychological aspects, probably it may be drug related. So you need to, the treatment will be slightly difficult to manage. That will also affect the retention of the denture. Always this kind of inability in with the, and you have a very good alveolar ridge, always the instability for the mandibular denture. Preferably your patient is sound enough with a good bone support, and if you can, always an implant supported over denture will be good for these kind of highly unstable over dentures. And the presence of the herpetiform ulcers in the mouth, that is the dentures mainly maybe coincidental to the condition, but some sort of the virus, antiviral drugs can be given as a remedy for this kind of situations. The painful click of the TMJ on opening or closing of the mouth, or tenderness of the muscles of mastication. Any patient who is having any sort of the change in the vertical dimension in fabrication, and which may lead to the TMJ disorders or the TMJ pain. But at the same time, you have to see that a patient who is having already a teeth problem, it is always better to give a non-functional cusp teeth for the posteriors to avoid this kind of pain in related to TMJ. So you are supposed to give a non-anatomic teeth for these kind of patients, and see that if there is any fault towards the vertical dimension, if it is being altered or if it is improperly recorded, you need to recorrect the denture by changing the vertical dimension. Always keep in mind that 2 to 3 mm of freeway space is mandatory for your denture fabrication. The patient complains of allergic to the denture material. So that's what I just told just a couple of slides back. That is a high residual monomer content in the acrylic. Always when you deliver the denture, we have to see that the unreacted monomer in the denture has to be completely eliminated. So how do we do that? We need to, after the denture acrylization, polishing and all those laboratory procedures are over, you need to place the denture in a plain water minimum of 24 to 48 hours. So that is definitely will help you to give a denture. The leaching of the monomer can be avoided. Secondly, if you find that the material is allergic, then we need to discontinue the material and we need to avoid the area of something like a metal-based dentures with a minimal of acrylic, or use high-quality acrylic. Never use any sort of self-care acrylic materials when the patient is allergic. Patient complains of the denture-based material, but we need to, if the patient complains of allergic to the denture-based material, we need to find out how far the allergic content the patient is having, so that we need to evaluate. Now the commissural cheilitis, inflammation of the angle of the mouth, and the excessive intraocclusal distance, that is also related to the vertical dimension, is also important to the commissural cheilitis. So when the occlusal plane of the lower teeth is too high, and to treat the problem, it is advisable to construct or to change or to go in for recording a new jaw relation and reset the teeth, correct the jaw relation, and go in for a new denture. Now I am coming on to the looseness of the denture arising from decreased retention forces. Looseness of the denture arising from decreased retention forces. When we say the looseness of the denture, two things comes to us is lack of peripheral seal and rocking of the denture. Lack of peripheral seal and the rocking of the denture. When we see the lack of peripheral seal, border extension, that is always, if you are, always I say that, how do you achieve a peripheral seal? It is by giving a perfect primary impression, and then you go in for a proper customized tray for the patient. Do a proper border molding, either with the low fusing compound or with the help of rubber-based material. So if you are doing a proper peripheral tracing or a proper border molding, you are going to mold the borders of the tray. You are doing by either by the hand manipulation, or you are doing by the functional movements of the tissues within the physiological limits. You are recording the peripheral seal, and that we call it as the border molding. So if that process is being properly done, definitely your peripheral seal is achieved to the physiological limits. If that is compromised, definitely you are going to land up with an underextension in depth as well as in width. When an underextension of your denture, if it is there, definitely that will lead to looseness of the denture, lack of peripheral seal. Overextension of your posterior palatal seal area, your pterygomandibular raphe, the posterior limits, if it is not being properly recorded. Overextension of your denture. So both are going to affect your peripheral seal. So if that is being located in your denture, you need to, either you need to reline. If the defect is more, you need to rebase it. That is very, very important to avoid the peripheral seal. Now the rocking of the denture, which we find is definitely first defect will be the defect of due to improper impression. Second is wrappage of the denture, over adjustment of the impression surface. You have to give a perfect impression. You have to make a proper primary impression first and then go for a final impression wherein you record all details. If it is a high arch palette, you have to use a good impression light body material to record the high arch palette properly. So depending upon the anatomy of your alveolar ridge, and always see that with the mandibular ridge, same as that of your posterior palatal seal, the mandibular ridge, you have to see that the retromolar pad area is being properly recorded. If that is not happened, your lower denture posterior seal is compromised. Residual ridge resorption will definitely affect the rocking of the denture, and you should not allow, or you should entertain your patient not to wear a denture more than 3 to 4 years. Don't make a point that you give a denture and don't commit them that your denture is wearing for your lifetime, or this is lifetime. Don't give a commitment like that. Your denture you need to change every 3 to 4 years, because your ridge is keep on remodeling. The ridge remodeling happens, you need to correct it, and excessive relief, whichever is needed, that also has to be given. So all these reasons, if it is not being properly taken care, the rocking of the denture also takes place. Now, the looseness of the denture arising from increased displacing forces. What do you mean by increased displacing forces? The denture borders overextension in depth, denture borders overextension in width, denture borders overextension in depth. So whenever your denture is having an overextension in depth, definitely that will affect certain areas, because there are chances of the denture to raise too much. You are encroaching onto the physiological limits of your oral cavity. That is what is happening with an overextension in depth. Inflammation and ulceration in the sulcus region will be affected if you are going an overextension in depth. So sometimes if a buccal to your tuberosity, normally if it is not, if it is underextended, that will lead to retention. If it is the denture is not being properly extended, the foot entrapment into that area will happen. If it is overextended during the physiological movement, the denture will get dislodged. So always see that your denture extension into the posterior limits, the posterior palatal seal area, as well as the tuberosity. Beyond the tuberosity area, the buccal pouch area needs to be recorded with proper care. And the denture bears where the overextension in width, denture borders, always we have to check the bulkiness in the posterior limit, the buccal pouch area. If you don't see the lateral movements of the mandible, and if you don't allow the coronoid process to come in contact with the upper tuberosity area, that you are not going to mold the buccal shelf properly. So that is happening, definitely you need to correct it. So there is a design error, you need to remodify it. Denture when there is not in an optimal space, that is the molars in the lower denture lingual to the ridge, optimum triangular shape of the denture if it is absent. So in that condition, that is you are not giving a proper space or a room for the or a space for the tongue. If that is happening, the definitely the tongue will be having the tendency to push the denture out. So you have to see that the teeth positioning is also very, very crucial, as well as your mylohyoid ridge. When you are recording the mylohyoid ridge, the S-shaped curve is properly recorded, and the extension beyond the mylohyoid curtain should not happen. That means your tongue movements has to be properly recorded. If these things are being properly addressed, the thick lingual flanges encroaching onto the tongue space, causing the lifting of the denture can be avoided. By thinning the lingual flange, excess pressure from the upper lip to the denture arising from the teeth too labily placed will be taken care. So this we need, if your teeth arrangement is not or has not been in a proper way, it has been done, you need to rearrange the teeth properly. Don't don't uh, uh, don't try to convince the patient. You find that there is an error, you try to correct it. That is always better. Now you come across the problems associated with the adaptation of the dentures. When we say the adaptation of the dentures, that is normally we find with the noise on eating, speaking, eating difficulties, gagging. So these are the things which we come across. So what are these things? The noise on eating, while the clicking sound, the patients lack the skill of the new dentures. That is excessive. What are the reasons for the clicking sound? The noise which happens. That is the change in the excessive vertical dimension, occlusal interference, and the looseness of the denture definitely will leads to the noise while the patient is speaking. That is clicking sound. That is related to your improper vertical dimension. The patient finds some eating difficulties due to an unstable denture. That is, you are trying to give a denture with proper retention by recording the proper anatomical structures, the lingual extension, the maxillary posterior limit, postal palatal seal area that we need to record without displacing the forces. Now, the common complaint which we come across with the patient, that is the gagging. Always the patients, when a new denture wearer, the gag reflex will be more, excess salivary secretion will be more. So these kind of things, the patient will find that the looseness of the denture. Always we find that the gagging, one of the common reasons which we find is the overextension of the denture, that too in the posterior palatal seal area. If the extension is too much posteriorly, definitely that will lead to a gag reflex. And the lingual placement of the upper posterior teeth will also lead to a gag reflex in the patients. So construction of the dentures to maximize the retention and minimize the displacing forces is very, very important. And we need to give him a new denture wearer. You need to give him a psychological counseling. Slowly, you motivate him to, if the patient has got a severe gag reflex, ask him to wear the denture for 4 to 5 hours. Slowly increase the time. Then ask him to wear for 4 to 7 hours. Slightly increase the time, and then once he is stabilized with the maxillary denture, then you move on to the mandibular denture, provided your anatomical limitations is being properly recorded. Secondly, we find finally we find with the speech problem. Commonly the patient find that the new denture wearer, they find that the words of pronouncing the words is not clear. Always you keep in mind that vertical dimension, if it is being properly recorded in the the 2 to 3 mm freeway space, you will get a speaking space, a range of 7 to 10 mm speaking space you will get. And if your freeway space is compromised, that means your vertical dimension is not being properly recorded. Then you need to correct it. That will definitely affect your speaking or speaking words, something like your yes, your the words pronouncing with the P, with B, the words pronouncing with the F, V. All these are related to your tooth position, the anterior teeth arrangement, the labial inclination of the teeth, the freeway space, what we have recorded in your jaw relation. All these things are being interconnected. So we need to see that the vertical dimensional accuracy, the presence of the vertical incisor overlap, all these are not is not excessive. So all these kinds, if it is being properly attended, definitely the speech problems will be sorted out. Now we find some of the problems which we associated with the retention of the retention and stability for the denture. What are the most common things which associate with the retention and stability? That means the patient complains that my lower denture lifts rather than the upper denture drops. When I say this, previously when we start with the practice, we have heard a joke from our senior practitioners, they say that I have fabricated the upper and lower denture, but I have charged only for your upper denture, and lower I am giving you free of cost. This is a small joke which we say to the patients. But now if you say this kind of joke to the patients, definitely you will get a case from the consumer court. Because now for anything, a denture, if it is given to the patient, if it is paining, the patient will file a case. So that is the era where we are going. So we need to give a denture which is underextended. We need to give a denture with proper extension, no overextension, no underextension, with a proper extension. That means the physiological, within the physiological limits. We need to fabricate a denture within the physiological limits. Tight lips, lack of saliva, these are some of the reasons which can affect if you find that there is salivary secretion is less, give them some salivary substitutes. And sometimes the patient says that dislodgement when coughing or sneezing. So these complaints you need to address. You are giving a removable denture, but you cannot commit to the patient that your denture will not dislodge while coughing or sneezing. Occasionally it may happen, but you can tell them that always try to, you provide all your denture stability and retention if it is good. You tell them that there is no way of preventing, but cover the mouth with a handkerchief before you do all this coughing or sneezing. But we find that the upper denture yawns while yawning, the denture dislodges. Always when you record your maxillary impression, you need to see that the lateral movements of the mandible, you do the mandibular movements to the right and left, both the lateral movements, and you wide open the mouth. When you wide open the mouth, you find that the coronoid process is going to help you in recording the posterior limit properly. If that is being recorded, definitely your upper denture, you see that the stability of the upper denture with the normal movements, not unexaggerated movements, you cannot predict. With the normal movements, if it is stable, your denture will not get dislodged in small yawning and all. The mouth is open to the full extent. The distobuccal flange of the denture may be too thick. So you need to see that whether this kind of recording is being properly done. The buccal surface of the teeth, if it is placed too far towards the cheek, that is a wrong thing which we have done. So you need to see that your teeth arrangement has got out of arch, overextended into the pterygomaxillary notch. When it is extended too much into the pterygomandibular notch, definitely when you opens up, definitely the denture will have the tendency to get dislodged. So if there is an area of irritation or the borders are overextended, it should be reduced. And if there is no evidence of extension, the patient should be cautioned to refrain from opening the mouth too wide, because you are given a removable denture, but within the physiological limits, you see that it is been recorded with all these things. If that is being recorded in your, so that what I say is your bottom molding is very, very critical. You need to see that the peripheral tracing has to be recorded with carefulness and with proper extension being recorded. Dislodgement of the dentures on taking some fluids, doing swallowing. So why does when you're recording, why do you ask the patients to say that you need a sucking movement? You record, you do like this. What happens? You are recording the muscles in the functional movement. So during swallowing, also you need to record the posterior palatal seal thoroughly with functional movements with the Welser-Wenner method. So when you do that, definitely your dislodgement of the dentures while taking on fluids also will be reduced or it will be avoided. So these kind of things, if you are grown in a gross mistake, you need to refabricate. Lower denture rises while the mouth is partially open. The main concern will be your lingual flange are overextended. Keep in mind that no overextended dentures will be stable in the patient's mouth. No underextended dentures will have retention, and that will lead to creating the break of seal. So all these two factors are correlated, which leads to the stability of your denture. The upper denture drops in while talking, that is poor bottle seal, improper frenal relief in the denture. That is also very important, improper bottle seal and improper frenal relief. Your labial frenum and the buccal frenum, and sometimes your lingual frenum and the lower labial frenum, lower buccal frenum, sometimes you'll be having multiple frenums. All the frenums needs to be relieved. Normally, we get from the labs, they don't take care about the relieving the frenum properly. You need to relieve it before you deliver the denture and correct the bottom molding. You check whether there is any overextension. Slightly, you can trim it off, slight modifications. But too much overextension, and if it is breaking your seal, definitely you need to recorrect your border seal. Now, what are the other difficulties which we come across with the denture? That is foot trapping under the denture. That is normally we find with the first time wearers as well as an underestimated dentures. A perfect peripheral seal, if it is not there, always that leads to the foot entrapment. So we need to cover the maximum possible area of the edentulous foundation and obtaining an adequate peripheral seal. That is very, very important to avoid the peripheral seal. So these are the common complaints which we come across: gag reflex or the underextension onto the anatomical areas and all. But when we have to see to the we have to see to the condition, like these denture when we are recorded, sometimes we have some sort of additional stability materials like denture adhesives can also be used in your private practice. So what does these denture adhesives and how does we use it? So there are some denture adhesives here, and we commonly have heard about Fixon, but there are certain good materials which are also available in the market, and we see that the prescribing a denture adhesive, is it a compromise? Is prescribing denture adhesive a compromise? I say no, because prescribing denture adhesives has been viewed by many prosthodontists and general dentists as a means of compensating for any defect in the fabrication procedures. So, but when we say like that, but we have to see the denture adhesives adds to the retention. But you cannot say that with the denture adhesives alone the retention and stability will not be achieved. So it helps you, it is an added advantage. It helps you to improve the chewing ability, reduce some sort of instability. The gross anatomical defects, the overextension, all those things will not be compensated by denture adhesive. It is something like an added benefit or added advantage, and you can use this kind of adhesives which eliminates the accumulation of the food debris beneath the denture, and consequently they increase the patient's sense of security and satisfaction. So even the most accomplished practitioners find difficulty in satisfying the patient. Always we say that if you are able to convince a geriatric patient at the age of 60 to 70 year aged patient with a complete denture, and the patient is happily able to wear the denture comfortably, I think you will be able to convince almost all the patients who comes to our clinic. So it is always that we should come to the level of their expectation, and for that the retention of the denture, and it is often considered and appropriate to prescribe a denture adhesive also for these patients. So the denture adhesives should not be used as a method to improve retention. I don't say like that in an improperly fabricated ill-fitting denture, but under any circumstances, the denture adhesives can be indicated as an additional method to enhance your retention. So how does this act? So normally we have the denture adhesive paste. You have the denture adhesive paper strips are available. You have available in the powder form. So it's powder and cream and paste and paper forms, it is available. So these denture adhesive powders, it absorbs the water and they sell to many times their original volume, and the viscosity of the powder is increased by, and make the saliva, it reacts to the saliva and thereby increasing the denture retention. Adhesive creams, will increase the viscosity of the adhesive creams, results in their removal of the air from the denture bearing. It becomes a thin layer between the tissue surface and the denture, and thereby the air entrapped between that area will be removed out, and it gives you a strong adhesion between your tissue surface and the denture. That gives a cushioning and a retention for the denture. So the requirements of an ideal denture adhesive is like it will be available as a gel, cream, or in the powder form. It is biocompatible, it is non-toxic, and it is non-irritant. It is neutral odor and taste. Its easiness for the application and removal, and it discourages the microbial growth. The denture adhesive paste, which is being available, good denture adhesive paste, which is available, it lasts for 12 hours and more. Increase the comfort and retention and stability of your denture. How does this material is being applied? The powder form, you sprinkle the powder over the tissue surface, but you see that the denture surface is very clean. You clean it off, you sprinkle the water, and then you apply the powder. If it is a paste form, you apply it in 3 spots, that is in the anterior and 2 in the posterior or in the palatal area. Wet the denture before the application of the adhesive. Small amounts of adhesives are applicable to the tissue bearing surface of maxillary. You apply it in the palatal area, anteriorly, and onto the posterior 2 drops. So, and in the lower, you apply it in the anterior area and 2 in the posterior area. So this paste will spread out once you place it into the tissue surface area and enhances the retention. You can, the diagram is will clearly show you how much and which all areas it can be applied. And how to see the denture after the denture adhesive application. The denture should be seated and held in place firmly by hand for 5 to 10 seconds. Any excess material flowing out, you, with the help of a gauze, you remove the excess adhesive, clean it nicely. The patient is advised to close in centric relation or centric occlusion several times to spread the adhesive and remove the air which is been entrapped within the denture. So that the material is being spread equally inside the tissue bearing surface area of the denture. So indications, we can use the same material to stabilize your jaw relation when you do for the jaw relation in your trine of the denture. This jaw relation and trine is very, very important. You do your jaw relation properly, check, stabilize the denture base. I request my practitioners to use self-cure denture base or the heat activated, the light activated denture based material for making a jaw relations, not the shellac based paste, because it gives you an additional adaptation to the patient. Because the stability of the denture base will be very good. So you are able to stabilize the denture base. If the platform is not stable, you are recording on an unstable platform. The jaw relation also will be, chances of the jaw relation to go slightly wrong. So this denture adhesive paste also helps you to enhance a stable denture base. Secondly, when you do the trine procedure is something like you are verifying all the procedures starting from your primary, secondary, and jaw relation. So you need to have a stable denture base, and patients with a compromised denture bearing area, immediate dentures, and as a prophylactic use. So these kind of indications are good for these for the denture adhesives, and you can use this material wherein patients with xerostomia, patients with hormonal changes or neuromuscular disorders, gross maxillofacial defects, retention, that is something like, for the patient who are undergoing radiation or radiation protection conditions, high profile patients with something like the politicians who are wearing dentures, public speakers, these kind of, you have an added advantage apart from the retention, stability. Moreover, it is always preferably try to give implant supported denture is always the best. But there are conditions where the patients cannot afford and go in for. So we need to at least go in for a good conventional complete denture. Advise this also to an added to that. And contraindications means in the sense of patients who are allergic, gross inadequacies in the retention of function. I told you in the beginning, this denture adduces is not a solution for under-extension or over-extension dentures. Your peripheral seal should be there, but this gives you an added advantage. That's the main thing. Retain the fractured dentures or dentures with the lost vertical dimension stably, and inability to maintain proper hygiene. The patient who is cannot maintain properly, better don't advise. You don't need to contraindicate. These are some of the materials which is being available in the market, and the polydent is it seems to be very good. Polygrip is an important material which is being available. You have, apart from the Fixon, what is being commonly from our college days, we have heard about Fixon. There are some this is imported material which we can commonly advise to our patients, a good material which helps us to enhance your retention. So the proper usage of these denture adhesive are beneficial to the patient in increasing the retention, stability, and it can enhance the comfort, improved function, and providing the psychological satisfaction. So that is an added, apart from handling with your normal anatomical, taking care of your impressions, taking care about with your jaw relation trial, and apart from that, you are giving one more added to give a solution to your retention and stability. You can advise the patient with the denture adhesives also. And to conclude, this denture fabrication of complete denture, I would like to say that it is basically an art wherein, as dentists, we mix the science of art with science, and both has to be taken care. That is, aesthetics also should be good. Your biological consideration also should be good. And when all these things are being properly controlled and being fabricated, considering all these parameters, definitely you are going to give a good complete denture. But in some situations, you may compromise where you are giving a denture for a totally resorbed ridge, or sometimes you will be having a patient with a very thick ridge, wherein you will not be having a proper interart space. These are some of the rare conditions where we compromise. But apart from that, a normal alveolar ridge wherein you can look into the anatomy and the impression part, the jaw relation part, the verification of all these steps in your training. If you look into all these things properly, I feel that you will be able to give a 60 to 70% good denture to the patient. And I always feel that a complete denture or a geriatric patient needs to be taken care psychologically also. We need to take into the confidence that you are able to give, or the patient should feel the trust in you and say that you can give a beautiful denture to the patient. And always, as my friend says, that we are the architects of smile. When we say architects of smile, we need to see the engineering side, we need to see the biological principles, and as well as an artist. So we need to culminate all these things to give a good denture. And I hope that you will be looking into all these problems as a solution for the problems. And I take this occasion to the Malanad branch president, Dr. Murali Krishna, as well as our secretary, Dr. Pradeep, CDE chairman, my student, Dr. Ronin, for inviting me to deliver a talk on this particular topic on the prosthodontic day for the general practitioners. And on behalf of the Academic Forum of Marbe Sailors Dental College, I thank the Malanadu branch, my own branch, for giving me an opportunity to share some of my knowledge with my practitioners. Thank you.
Thank you, Dr. Baiju. It was a wonderful presentation. In such a small time, you have to cover so much of things. We have few questions. The chat box also. So shall I read it out, Dr. Baiju?
Yes.
There is only a question here. Sir, can you explain briefly about instructions to be given for the first 24 hours of denture delivery? I mean, on the day of the insertion. By Dr. Akhil.
Normally, if he is a new denture wearer, considering the patient is a new denture wearer, we always advise the patient to start wearing the denture for a minimum of 6 to 8 hours a day. And when you deliver the denture, advise the patient for 2 to 3 days, you teach the patient how to remove the denture and place the denture properly. We need to see that the upper denture should be placed first and then the lower denture. And when you're removing the denture, it is preferably better to remove the lower denture first and then the upper denture. And the proper maintenance of the denture, that is the denture hygiene maintenance with the denture cleaning brush, is very, very mandatory in the plain water. That is very, very mandatory. Once in 2 weeks, once in a week or once in 2 weeks, denture cleansing tablets are available. You can keep the denture in 24 hours with denture cleansing tablet and clean the surface, inner surface nicely to avoid the food deposition and not to create any sort of the fungal growth around the tissue surface area. Maintain the denture thoroughly so that the patient should not have any sort of candida infection. And gradually the patient should be advised to take soft diet first and gradually increasing to the diet to the higher biting forces. These kind of things has to be taken care.
Thank you, Dr. Baiju. Any more questions on the floor? I don't think there are any more questions. Now I request our Honorary Secretary, Dr. Pradeep Philip George, for the vote of thanks.
Thank you, Mr. President. Good evening, all. Respected President of IDA Malanadu, Dr. Murali Krishnan, our speaker, Dr. Baiju, patrons of MBDC College, Advocate C.I. Baby, Secretary, Dean, Dr. Verghese Mani, sir, Indian Prosthodontic Society Office Bearers, President, Dr. Rohit, Secretary, Dr. Rupesh, moderators of this function, Dr. Arun George and Dr. Brijesh, our CD chairman, Dr. Ronan Sebastian, and all the people who are attending the CD. It is indeed a great launch, what we've had for our 2022 CD series, which we are going to come out with. And IDA Malanadu shows our gratitude to each one of you for attending the CD and also making this program a great success. When CDs are there online these days, it just so happens that, we are sort of fed up with the CDs. And we say maybe we don't want more CDs. But then when people come out with such interesting topics, we can never resist such beautiful CDs. And that is what the reality is. Let me actually go on to my duty without further delaying. The presiding officer of this CD program, our President, Dr. Murali Krishna. Thank you, Dr. Murali, making this program and for arranging all the technical details in this program, a great success. Thank you, Dr. Murali. And the most important person who was there today, our esteemed speaker, Dr. Baiju Paul Kurian, Principal of Mar Basilius General College, our past president of IDA Malanadu. I don't know what to say. There are a lot more to say about him. Sir, what you've done today is a great thing. And we have witnessed one of the best CDs in Malanadu history. Thank you, sir, for this great CD. And we hope that, Marble Sirius General College will associate with IDA Malanad for furthermore CDs, and we'll have a great rapport going together, sir. Thank you, sir. I also take this opportunity to thank the patron of MBDC College, Advocate C.I. Baby, also the Dean, Dr. Verghese Mani, sir, for giving us the opportunity to associate with MBDC and conducting this grand function. Thank you, both of you. And Indian Prosthodontic Society office bearers, what do I tell them? You know, when something of this magnanimity came, and this is something which the Indian Prosthodontic Society Kerala chapter is hosting also. So when they asked us, like, you know, are you interested in doing it? We didn't even need to think back. All we had to say was yes. So thank you, President Dr. Rohit Raghavan and Secretary Dr. P.L. Rupesh for the great opportunity what you have given us. And again, we sincerely believe and hope that, you know, we will continue this association and we'll have more CDs with Indian Prosthodontic Society Kerala chapter. And the moderators of this function were Dr. Arun George and Dr. Brijesh. Thank you, both of you, for being the moderators and helping out in conducting the CD in a very well-structured manner. Thank you. I also take this opportunity to thank each and everyone who has come here, all the attendees, our past presidents of IDA Malanad, our senior members of IDA Malanad. I can see a lot of even Indian Prosthodontic Society members being here, other than, you know, our members. Thank you all for coming and making this a great CD. Sorry, I have to, in between, you know, I just missed the person who inaugurated the function, our own CD chairperson of Kerala, IDA, Kerala State, Dr. Nishant. It was his great kind-heartedness to come and actually inaugurate our launch of CDs for IDA Malanad. Thank you, Doctor, for being with us. Also, I take opportunity for all the attendees and all the people who have attended the CD today. Last but not the least, the man behind the show definitely was our CD chairperson, Dr. Ronin Sebastian. Ronin, this is a very good start which you have created. We just, you know, it gives us more pleasure to be there to see and watch how you're going to build the CDs, the series of CDs, what IDA Malanad is going to bring about. Thank you, Ronin. With a single word, I thank all the people who are there here. Thank you. Thank you.
Thank you, Pradeep. So let us conclude the meeting. Once again, thank you all. Thank you, IPS. Thank you, Dr. Baiju Polkurian. Thank you, all the members. Thank you.
Thank you, Murli, and thank you, Pradeep. Pradeep, that was a wonderful, you know, words of gratitude. I really loved listening to you.
Thank you, sir. Thank you.
And yes, Ronin also, thank you so much. You know, obviously, you know, we'll work out some, you know, various programs together with our IPS Kerala chapter and of course your branch. We'll see.
Sure, sir. Sure, sir. We'll work out.
Great.
Ruben sir, we are coming with the Free Danger program.
Yes, yeah, I know, yeah.
We will associate with Malanad branch also.
Absolutely.
Our past president Terry had.
He's also online, yeah. Dr. Terry?
Yeah, Dr. Terry is also online, yes.
Terry, yeah, and later on this, yeah.
He will be here today. Me to associate for Free Danger program. So we will definitely make it a good community outreach program.
Sure, perfect.
Yes. We have found out some orphanages also where we can give Free Danger programs.
Definitely to support you. Terry will be there to our IPS.
Yes.
Our
Thank you so much.
Will be there to support.
Thank you. In association with Malanad, we'll do a lot of the Free Danger programs this year.
Okay. Thank you.
Thank you, Dr. Baiju. Thank you, Dr. Rupesh. Thank you.
Thank you.
Thank you.
Thank you, Baja. Thank you so much.
Night, everyone. Terry, hello.
Good night.
Hi.
Okay. Bye-bye. Good night.
Bye.
Bye. Good night. Take care.
Good night all.